You know, আমাদেরকে আগে খেতে হবে, তাই তো? First thing, after crying, after the birth, baby wants to eat. So that's how our oral cavity is being presented, right? We have our teeth, not in the babies, with time. What is this structure? This is uvula. And this structure is anterior pillar of the tonsil. This is the posterior pillar of the tonsil. In between there is tonsil, right? This is our tongue. Tongue has many important things, underside, overside, different forms of papillae. That is in your anatomy, you have been taught. This is the frenula of the tongue, and we have the openings of the submandibular glands, right? Salivary glands. This is our upper lip, this is our lower lip. So grossly, this is the oral cavity, right? Now coming into some important diseases of the oral cavity. Okay, see the first picture. This type of petechial spots into the oral cavity, especially in the pediatric patient, it's being seen. We call it herpingia. It's also called hand, foot, and mouth disease, right? Mostly by Coxsackie A virus. Pediatrics পড়া হয়েছে তো pediatrics এ? This is the typical picture. These pictures you will get every day, okay? This is herpes simplex type 1. And if it is one-sided palate is involved, mostly it is herpes zoster, right? Just little bit of overall idea এখন তোমরা রাখো, okay? Later on we will discuss it in more detail. This is very common, commonly mistaken as acute tonsillitis. This is not acute tonsillitis. This is infectious mononucleosis, okay? By Epstein-Barr virus. You see, this is a papillomatous growth here. It's also being done by human papilloma virus, okay? And this is the famous Kaposi sarcoma. These are all the real life patients, right? Kaposi sarcoma by HHV 8, mostly seen in AIDS. This is bacterial tonsillitis, okay? How to differentiate between bacterial tonsillitis and infectious mononucleosis? Anybody? মাইক্রোবায়োলজি তো পড়ানো হয়েছে তো নাকি? তাহলে মাইক্রোবায়োলজি পড়ে লাভটা কি হলো? If you cannot determine how to identify, how to differentiate between, what is the use of microbiology? So this is a picture. Look carefully. This is a picture. I'm telling you, this is acute bacterial tonsillitis, and this is glandular fever. How to differentiate it? Very difficult to differentiate, okay? There are some things clinically you need to ask. How much lymph node is involved? This is the most important one, right? How much lymph node is involved? If there is gross, extensive lymph node enlargement, because any infection in your head and neck region, there will be some cervical lymphadenopathy, always, okay? So if there is very extensive lymph nodes, cervical lymph nodes, then mostly it goes into the favor of infectious mononucleosis, okay? Second important point, that is the hallmark. If there is petechial hemorrhages in the palate, okay, along with this appearance of the tonsils, this is mostly infectious mononucleosis. As well as if there is spleen is enlarged, right? Spleen is not always enlarged, okay? If it is stays for longer period, then spleen might get enlarged. If it is there, it's very specific for infectious mononucleosis, right? Other things are similar. Both the patients will have fever, pain, difficulty in deglutition. We call it odynophagia, ear pain, everything, okay? So if it is confirmed that infectious mononucleosis, how will you confirm it? We'll take a swab, right? And do some Epstein-Barr virus, virology, serological investigations, as well as some bacterial culture. This is the most confirmatory test. If it comes in the bacterial culture that there is a bacteria, then it's mostly bacterial tonsillitis. What bacteria is most common? Streptococcus pneumoniae, right? The most common one. Then in glandular fever, we will not give any antibiotic, right? Antibiotic will delay the improvement. But in bacterial tonsillitis, we will give mandatory antibacterial therapy. Right. This is another case, scarlet fever. Okay. You have all read it probably. This is a case in oral cavity, candidiasis, that you get it in clinical practice. This white spots, the base is little bit erythematous. Typically, the patient is having some history. Okay, যার তার candidiasis হবে না. In otomycosis, I have told there are few patients who are in more risk, right? Some patients profile few diseases and all that leads to more fungal infections. Like, right? So name some disease. First HIV. Barbar boli. HIV is not the most common. Do you get HIV nowadays? Very rare. Most common is diabetes, uncontrolled diabetes. Okay. Then HIV as well. Chemotherapy, transplant patients on steroids. Patients are having very long-term antibiotic therapy for unknown reasons. These are the predisposing factors. But for oral thrush, there is another factor because lots of patients are having COPD nowadays. The patients are taking metadose inhalers, puffs, all these things. And after each puff, patients are advised to do the gargle, mouthwash. But mostly patients do not follow it. These patients are prone to develop oral thrush. Okay. This is a case of Pemphigus vulgaris. You will study in your dermatology. This case, these patients are always coming to us. This reticular pattern, Wickham stria. This is a classical case of Lichen planus, right? This is the scurvy. Look at the gums, gingiva, periodontitis, all these things. In older days, the Navy people on sea voyage, they used to get this vitamin C, right? This is gingival hyperplasia, lots of drug side effects. This anti-epileptic phenytoin and all. This is a Leukoplakia, right? This whitish sheet-like structure, right there. Okay, it's not easy to move. Shada spot. Lots of patients coming to us asking, is it a cancer? Is it a cancer? It's not. Is there any chance of developing cancer? Yes. How much? Extremely low. Extremely low, right? This is a Fissured tongue. This is the classical geographic tongue, having no clinical importance. And this is typical Aphthous ulcer, painful. Aphthous ulcers are always painful, right? It comes with any viral disease in our body or immunological any problem, immunological diseases, and it goes off spontaneously. This is hairy tongue, and this is Macroglossia. Macroglossia is seen in, this is a question that can be asked in your MCQs. Most common cause, most of the Down syndrome patients have Macroglossia, right? Amyloidosis, we do tongue biopsy. Acromegaly, sometimes lingual thyroid, unknown reason also. Sometimes without any reason, we can have Macroglossia. So, Leukoplakia, what is the chance of carcinoma? 5%. But this is an erythroplakia, right? The surface is whitish here, it's reddish. It's a high risk of developing carcinoma in these cases. Okay, if you get this type of lesion, reddish, with this kind of appearance, the base is not elevated. The DD is between erythroplakia and Leukoplakia, right? So it is a red plague, and in case of Leukoplakia, it is a white patch. The risk of developing carcinoma is 50%. We will biopsy these patients, right? If there is any chance of dysplasia, we will repeat biopsy after a few months, okay? Any single chance, if you get that there is developing any squamous cell carcinoma in these patients, we will act accordingly. If you ask this question, most common cancer in your head and neck region, except thyroid and parotid, the answer will be squamous cell carcinoma. Okay, the most common cancer in thyroid is papillary carcinoma of thyroid, and most common cancer in parotid is mucoepidermoid cancer, right? So mostly it is squamous cell carcinoma, and these risk factors are mostly for most of the head and neck cancers. Number one, tobacco. Okay, smoking cigarettes, cigars, pipes, anything. Okay, anything you use, all are having high association. Heavy alcohol use, excessive sun exposure, especially in fair people. তাই তো ফর্সা হওয়াটা কোনো ক্রেডিটের ব্যাপার নয় অ্যাকচুয়ালি। ইউ আর মোর প্রোন টু ডেভেলপ skin cancer. Having fair skin, over the age of 40, being a male, right? Why? First of all, with time, there is some genetic changes already, but males are more prone to all these bad habits. Right? Human papilloma virus infection is getting more common, and a weakened immune system, obviously. So how will you manage any head and neck cancer? Clinical examination is done. Then what? We will do a radiological investigation, assessment, and some cytological or histopathological examination, right? So either I will take a biopsy, or if possible, we will take a FNAC. FNAC means fine needle aspiration cytology. So not many tumors are giving good results with FNAC, but we need a imaging and this biopsy, right? After the biopsy, if we get that it's a squamous cell carcinoma, then we will proceed further, right? What imaging we will do in this case? We can do many things. What is the most important first investigation? CT scan. Why? CT scan কি দেখব? Every imaging or investigation is supposed to help us, তাই তো? Help the surgeons, help the patient. So we will look that this tumor is not infiltrating into our any bone, right? This can also be assessed with MRI as well. So CT is more easily available. So that is the first investigation. We will do USG as well. We can do USG as well. Why? USG is the best investigation for assessment of the cervical lymph nodes. Okay. So patient jodi disease, this cancer is not limited to tumor, your lip, it's getting locally metastasized to your cervical lymph nodes. Then overall the prognosis is getting changed. Okay. At least 50% reduction of mortality, 5-year survival or the disease clearance if the patient is having cervical metastasis, right? So metastasis actually দু ধরনের হয়, একটা হচ্ছে local metastasis, local infiltration and local lymph nodes are getting involved, that is local metastasis, okay? And if it is getting distant metastasis, it's an advanced tumor always. ঠিক আছে? So for all cancer we use TNM staging. Okay, T for tumor, N for lymph node, M for metastasis, right? We follow some protocols like HACC protocol, like all these things, and we prefer to be staged as TNM staging, not any stage 1 tumor, stage 2 tumor. These are all not required at all, okay? Mostly TNM staging. Okay. This is a case of angioedema. Okay, patient typical history, sudden development, যে মুখ, চোখ, জিভ, everything ফুলে গেল, okay? After eating something, after getting exposure to some pollen or anything, okay? This patient comes to us, sometimes may come to us with severe respiratory distress, right? The larynx is having so much of edema. So how to treat this patient? Patient তোমার কাছে এলো, একটা চাইনিজ রেস্টুরেন্টে চায়না টাউনে গিয়ে কিছু একটা খেলো, অক্টোপাস, ঠিক আছে? তারপরে একটা সিভিয়ার অ্যালার্জি নিয়ে এলো, তাই তো? দিয়ে তারপরে দ্যাট পেশেন্ট ডেভেলপ অ্যাঞ্জিওএডিমা, বা পাশে একটা গাছে ভীমরুল হয়েছিল, ভীমরুলের চাকায় একজন কেউ ঢিল মারলো, ঠিক আছে, ভীমরুলটা এসে কামড়ালো, তারপরে পেশেন্ট ডেভেলপ দিস থিং, সিভিয়ার ডিস্ট্রেস, রেসপিরেটরি ডিস্ট্রেস। হাউ টু রিলিভ দ্যাট ডিস্ট্রেস? ইন্টুবেট করবি তো, এয়ারওয়েট মানে একটা এন্ডোট্রেকিয়াল টিউব পড়াতে হবে। হাউ উইল ইউ পুট দ্য এন্ডোট্রেকিয়াল টিউব? দেয়ার ইজ সো মাচ অফ ইডিমা, you cannot see anything. So in these cases there is a possibility that after a failed intubation attempt, পড়াতে পারলে ভালো, যদি তুই না পারিস then you have to go for tracheostomy. But before that we can give some very important drug, adrenaline, right? IV, IM, oral adrenaline হয় নাকি? Forget about dose. What is the route? Sure. How many for IM? How many for IV? You are for IV. Logically কি মনে হচ্ছে? Which will act faster? You are not a general public. তো এটা সেট আপে এসছিস, logically which one should act faster? IV should act faster, but we will give IM. Okay, that is the protocol, right? IM একই রকম ভাবে absorbed হয়. It will take similar time. Okay, and adrenaline mostly given IM, safer. Okay. Obviously, in OT setup we give IV, but for this reason IM is preferable. And what are the medications? Penicillin is one of them. হাই অ্যালার্জিক টেন্ডেন্সি, তাই তো? ড্রাগ অ্যালার্জি জিজ্ঞেস করা হয় তো হিস্ট্রিতে, কোনো ওষুধে অ্যালার্জি আছে কিনা? বিকজ অফ দিস রিজন। ইফ ইউ ডু নট আস্ক and give this medication, this will happen. Ultimately patient will die for nothing, তাই তো? একটা ওষুধ খেলেও ডাক্তারবাবু মরে গেল তারপর। Does it sound good? Because you are the one who prescribed that medicine. Okay, this will haunt you for life. Suppose a small child, you did not ask for any allergy or did not tell the patient that this, if any allergic symptom or anything appears, stop the medicine, right? And another hereditary disease, this one, C1 esterase inhibitor deficiency, that is very important. It gives again and again this hereditary angioedema, right? How you treat it? Already bola hoyeche. Now, we are coming into this tonsil thing because this will be asked in your exam. So tonsil niye onek bhabe bola hobe. I am not interested in all these things. What is the indication of tonsillectomy? How will you do that? All these things. I will give you something. I will tell you something which is usually not written in your books elaborately, right? So you know, in few cases, in tonsillitis, chronic tonsillitis, other things, if there is any tumor, if there is any need for any sleep apnea surgery, we usually perform tonsillectomy. There are many methods of doing this. We can do it nowadays with coblator, with laser technology. We can do it with cryosurgery even, okay, or cold steel knife surgery. There are many methods. The basic thing is we need to remove tonsils if it is indicated, okay. So tonsil is not the one. Tonsil is what is tonsil actually? It's a lymphoid tissue, right? It's not a lymph node, is it? It's a lymphoid tissue. Usually it gives it helps you to build up your immunity in the initial few years of life. 3 to 4 years of life, up to 3 to 4 years, it helps you to build your immunity, right? So, tonsil and tonsil-like other tissues, it makes a ring around your oral cavity, oropharynx and all these things. These are all similar things, okay? Few have capsule, few don't have capsule, but the structure, architecture is more or less same, right? So this is the palatine tonsil, we call it the tonsil. If we tell tonsil, that means palatine tonsil, right? Again, similar tissue is lingual tonsil. There is something called adenoid that is in your nasopharynx, and around your eustachian tube there is something called tubal tonsil, right? So these all forms the Wilder rings. And this is your arterial supply. Keep this picture in your mind, this will be asked in your exam. Okay? So I have told you that external carotid artery branches will be asked. I will ask you. So this is the thing, this is the external carotid artery, and from the external carotid artery one branch, this is the lingual artery one branch, this is the ascending pharyngeal artery one branch, and this is the maxillary artery one branch. So 4 important branches from the external carotid artery supplies the tonsil, right? So it has a rich vascular supply. So what is expecting, what do you expect after surgery, what complication is most common? Bleeding, right? So many supplies are there. Is it not very easy to get bleed after tonsillectomy? Okay, and it's dangerous. Why? Because the tonsil stays just over your airway, right? If any bleeding goes to your larynx and lower respiratory tract, what will happen? It's not hemothorax. What is hemothorax? Hemothorax is something different. Hemothorax is having blood between your pleura and your lung. Okay, so that is the aspiration. Okay, so these patients will ultimately develop ARDS and pneumonia and all, consolidation, and can die. If there is severe bleeding, patient can go into hemorrhagic shock, right? So bleeding is very important from tonsil. That's why each and every exam you will be asked one question. If one question will be asked, that will be asked about bleeding after tonsillectomy. Okay? So you have to remember the name of the blood supply. From facial artery there is a branch. From lingual artery there is a branch. We gave it the name. We gave the name of the vessels like dorsal lingual branches, ascending palatine branches, descending palatine branches, tonsillar branches of the ascending pharyngeal artery. But the concept is same. Okay? Sorry. This is a post-tonsillectomy bleeding. Looks like this. After tonsillectomy, suppose after 2 or 3 days, patient is coming with this appearance. The whole raw area, tonsil area there is either active bleeding or there is clot. Okay. So this is a typical scenario. 5-year-old boy, 3 hours ago adrenal tonsillectomy done. Now, after surgery, you went for a post-op round and you saw that this is the picture. Okay. So what will you do? After 3 hours, patient is bleeding hoche. What will you do? We'll take back the patient into OT, right? We'll intubate again and close the bleeder. Okay. So before that, we have to assess how much bleeding already the patient has. Right? If the patient is already is having this very large amount of bleeding already is there, then we have to manage it. When we manage it first, okay, we have to give this fluid and all, fluid resuscitation, everything, and as well as we have to shift the patient to the OR. So these are the questions. No need to bother about it. So how will you calculate? Bolus is 20 into body weight and 4:2:1 formula per hour. এটা সার্জারিতে পেডিয়াট্রিক্সে বারবার পড়ানো হবে, how to resuscitate the hemorrhagic shock. And what are the signs of dehydration? Skin turgor is lost, increased capillary refill time, tachypnea, shrunken eyes, dry tongue, all these things, BP is down. According to, it depends upon the grade of shock, which grade of shock the patient is having. Glandular fever already told, but there is a question, okay? Suppose this patient is having glandular fever and you are having confusion whether it is acute bacterial one or the infectious mononucleosis, right? So which drug is usually should be prohibited because this can give some allergic reaction. Call it, I forgot the name, something Jarix, there is a name, okay, I will tell you later on the later classes. But you should not give amoxicillin, right? This patient. So how to diagnose if it is a infectious mononucleosis or not? The Paul panel test, okay, or monospot test, okay. So larynx is something I will discuss in next class, but at least keep an impression of this picture. I will ask in the later classes, you have to mark all these things. What is 1, what is 2, what is 3, what is 4, what is 5. Okay? This is the coronal section, cut section of larynx. Right? Like 2 is epiglottis. Okay? So I will ask you the next class. Larynx anatomy will be little bit taught here. Okay? Otherwise, you will not understand the other diseases. Okay? Thank you.